The views and opinions expressed on this program do not necessarily reflect or represent the views and opinions of 580 WCHS or West Virginia Radio Corporation.
And a very pleasant good morning to you. You're listening to Ask the Expert, WCHS, the voice of Charleston. I'm Dale Cooper. Thank you so much for tuning in on this Wednesday morning. I'd like to welcome into the studio this morning, first time into our studios, but from WVU Physicians of Charleston, who has been a guest on our program for some time now. But Dr. John Bishara is here with me this morning. Dr. Bishara, how are you doing this morning?
Good. How are you?
I'm doing very well. Thanks for your time this morning and coming in and talking about some of the issues that you're a specialist in. Now, we're going to be talking about pediatric pulmonology and sleep management. Just for a moment for the folks that are listening out there, by the way, you can find out more information online. You can go to WVUPC.com. That's WVUPC.com. Or you can give us a call this morning, 304-345-5858. 304-345-5858 is the number that you can call and get a hold of us this morning if you have any questions. And Dr. Bashir, I'd like for you to just take a moment to kind of introduce yourself, where you went to school, if you live here locally, what your background is in medicine, things along those lines.
Sure. So I did most of my training in New York, Long Island area, did college, medical school, pediatric residency and training, and my first fellowship in pulmonology or lungs. And I headed over to the West Coast and Los Angeles, and I did my sleep medicine training there at University of Southern California and Children's Hospital, Los Angeles. And I decided to follow my sister, who's an orthopedic trauma surgeon here, and the rest is history.
Well, we appreciate you coming to West Virginia. Thank you very much. We definitely need as many specialists in this area, especially in medicine, as possible. So thanks for coming to West Virginia to practice. And this is really a pretty specific area with pediatric pulmonology and sleep management. I want to talk about, I know that a lot of this kind of ties in a little bit together. If there was an affliction that a lot of children had to deal with, that maybe is that parents don't really know about that much. Like it's something you see fairly common, and people are surprised at just how common it is. What are some of the things, or maybe the leading thing that you would like to make folks aware of?
I think for parents to realize that snoring in children is no longer cute. It's not little Johnny, little Kim that has snoring like daddy or mommy does. No, it could be something serious. We do see sleep apnea in children, about 2 to 8%, and that number was really underestimated.
And so when we talk about sleep apnea in children, does all of the problems that are associated with apnea in adults also translate maybe even more so to children, as far as not breathing for long amounts of time and it causing problems and stuff like that?
Not quite, but we do see young children have these pauses, these gasps, these arousals after a snoring episode. One thing that is quite differently in children than adults, when you don't have a good night's sleep, you have daytime sleepiness. Mm-hmm. Children actually can become hyperactive. So we do see a lot of evaluations for children who snore and possibly have some sort of ADHD or hyperactivity.
That's interesting. So when you're talking about observationally what you might see in your child, it could be clues about when they're awake that will give you an idea that they're having problems when they're asleep. And it's not always manifested in droopiness, sleepiness, and things along those lines. It can also be hyperactivity?
Correct.
Interesting. So if you're a parent out there, and some of the things you said, snoring's not cute, I have an 8.5-month-old, my first child. So I immediately go back to my young child who sleeps at home, and you say snoring. And so what is snoring? What would you consider snoring? Is any noise that a person or a baby makes considered snoring, or is there a particular type of timbre or a thing that you look for to be considered that?
If they're snoring like you or myself, then parents will usually tell me about it. They'll say, "Oh, he snores like his father."
So real gravelly, like where you're actually making some fairly aggressive noises.
Correct, and it's parents usually say it's loud snoring, like those snoring that's not. It's occasionally or it's not seen daily. Then I won't get too concerned about it. But if parents say No, they snore loud. I can hear them across the hallway.
Yeah, okay.
Or they just snore every day, and their head, I put them down on their pillow, and I usually find them on the foot of the bed, or they're wrapped around like a Swiss roll.
Right.
So usually they would need to be evaluated.
And if there's a child that is diagnosed with some sort of apnea, what's the treatments and is that something they want to live with their entire life? Is there treatments for it that may help with that?
So I would tell the families it depends on the severity of sleep apnea. The way we usually evaluate for sleep apnea, especially in a child, is a sleep study.
Mm-hmm.
They come into the sleep center, which is at the CMC General. It's done every day except for Wednesday, and they sleep overnight pretty much. The child has a nice bed. The parents are alongside them in the room on a pull-out chair, and we evaluate how their breathing is at night. And we split it up between just regular snoring, primary snoring, if it's mild, if it's moderate, or if it's severe. Usually in young children, the biggest culprit is large tonsils, large adenoids. Most of the time, the treatment would be to remove large tonsils, large adenoids. And then we would evaluate afterwards with another sleep study to see if it resolved. If it's resolved, great. Have a nice time sleeping.
Sure.
Now, as children get older, there is this rising epidemic in pediatrics, especially with obesity.
Mm-hmm.
They behave like adults now. Tonsils and adenoids may still be a culprit, but usually it's the weight. And they now behave more like adults. And we usually see those children, the 11 to 12 and older, the adolescents, or the children that are approaching college years. And those children with sleep apnea really get treated similar to adults. They usually get treated with CPAP, which is just a medical air blower.
Right.
So we have them on those machines, and we evaluate them. The purpose of treatment is to really help with the symptoms of untreated sleep apnea. And the biggest symptom, especially for young children and adolescents, is problems with executive functioning, meaning they have problems with making proper decisions. All teenagers have problems with making the correct decisions,
Sure.
But usually they have issues with certain everyday function. They can't concentrate in school. They can't think of how to do a math problem. And those issues, when you get their sleep to be treated effectively, those issues really go away.
You know, it's always an interesting discussion. I mean, when we start talking about medical issues, and then you really realize when you talk about holistic medicine, not holistic as in the alternative medicine, but the whole body medicine. When something along these lines, a teacher or a counselor or a parent may observe a child only in a school situation or only in a learning environment and think they might have a learning disability, they have attention problems, like you said, like ADHD or something along those lines, that they're lazy or sleepy, or, you know, there could be any types of things that are attached to that child, where really if observation was made at home and you stumbled across some of these things that could be happening with sleep problems, there could be a direct causation there, not just a correlate, but an actual causation there where you addressing those issues could help with some of those symptoms that the child is having at school. That's a really important thing for folks to understand and to learn out there.
Absolutely. The biggest problem is when parents put children to bed, they're away from the room, and so they don't know.
Right.
So, and I highly encourage that children should sleep in their own rooms.
Mm-hmm.
And biggest observation that parents will say, you know, I'm not there to see my child sleeping, but when I do poke my head in, I do hear this, I do hear that. And sometimes teachers will evaluate, sometimes the general pediatrician will say, well, he snores, he has large tonsils, and I'm hearing some reports from the teachers of behavioral issues, moodiness. Let's evaluate his sleep.
And
And that's the biggest thing.
it really takes that one person to make the conclusion, let's go ahead and just check this box. Even if it ends up being nothing, we can at least check it to see if that could be part of the problem. And in a situation where it is, you could probably make a considerable academic change in a student, or at least their comfort level at school and their interactivity and things along those lines. I think that's fascinating, and probably something that's not known as commonly as what it should be out there. Our guest this morning is Dr. John Bishara. He is with the Pediatric Pulmonology and Sleep Management, WVU Physicians of Charleston, pediatric specialist in the CAMC Women's and Children's Medical Office Building, 830 Pennsylvania Avenue, Suite 408 here in Charleston. You can find out more information online, WVUPC.org. That's WVUPC.org. Their phone number is 304-388-1552, 304-388-1552. We are taking calls this morning if you have any questions at all about the subjects we're going to be talking on. We were talking about the sleep apnea, especially in children just now. We're going to talk a little bit more about some other sleep disorders that happens while you're actually sleeping, like sleepwalking, night terrors, things along those lines. If you have any questions about those for maybe a child in your life or a grandchild or something like that, you can give us a call this morning. 304-345-5858. 304-345-5858 is the number that you can call, and we would be glad to get you on the air with Dr. Bishara. I did want to start talking about some of these other issues that are less breathing related and more into things that happen at sleep time, because there's a lot of things that happen with children with bedtime problems where wake a lot during the night. You have irrational nighttime fears. Sleepwalking is actually, a thing that does happen. So is night terrors and things along those lines. Again, kind of the same question we came to with apnea. Are any of these particular things that happen once a child's asleep? Is there anything that you find is very commonly underdiagnosed that a lot of children that you see end up having?
Not underdiagnosed, but I would say that if parents are not aware, then it would go unnoticed and undiagnosed. Most of these nighttime sleep issues are not too significant. Most of the time, the treatment or the management is reassurance, like night terrors or nightmares. Night terrors and nightmares, even though they sound similar, they're quite different. Night terrors is a lot of grandparents will say, in the middle of the night, he or she screams and it's blood tearing, like my back of the neck, his hair like just jumps off. I run into the room and I see him or her sitting up, sweating, their shirt is soaked, and they're just looking right through me. The next day, he's walking, just eating cereal, and I'm up all night worrying about him, and he doesn't even know or he doesn't even care. That's night terrors. That's a perfect prime example. Children do not remember. Parents remember, grandparents remember, because it's like life-changing. But most of the time, all we say to parents and grandparents or whoever takes care of the children is we provide reassurance. It's usually affects more of the caregivers than the child. You just cuddle them, you just get them back into bed, and they'll sleep it off. And usually the next morning, they're unaware of what happened the night before.
And oftentimes then having sleep terrors like that is not necessarily the sign of something else that's going on. Oftentimes it just manifests on its own and it will go away on its own. There's not really any long-term repercussions for it.
Not usually. It's a small percentage. There may be some sort of psychological issue or some traumatic event, but the majority of times it's just another sleep issue that we tell caregivers it is fine. We provide reassurance and make sure that they just provide the child a nice sleep environment and get them back into bed.
Yeah, I find what you said really interesting to start with there being different things between nightmares and night terrors, because a lot of people, we have just commonly when lay people talk about different things, they start using diagnosis interchangeably. A lot of times I suffered when I was younger a lot from migraine headaches, and it was diagnosed. I was on medicine for it. It was a real life migraine headache. But so many people, when they have a bad headache that makes them a little uncomfortable, they're like, oh my goodness, I'm getting a migraine. And I think sleep terrors, a lot of time people substitute when they're having dreams or nightmares, they substitute night terrors in for that. So they're saying, I'm having all kinds of problems. I'm waking up every night with night terrors, et cetera, et cetera. That's probably not what's going on with that person. They're just having nightmares or a dream or whatever it might be. And they're just substituting in another diagnosis because it sounds more severe.
Correct. Usually night terrors occur usually between 12 and 2 a.m. The specific part about night terrors is they don't remember it the next day. The way I tell families is everyone watches Nightmare on Elm Street. You remember that nightmare. Mm-hmm. If you're able to remember that dream, that's a nightmare. Now, there's a difference between a nightmare and a bad dream.
Right.
Nightmares you wake up from, you're sweating, you're clammy, you're hot, you're like, oh my God, that was a nightmare.
So nightmare is actually a clinical term different from just a dream. So that is something that you will have a physical reaction to.
Correct. I would wake up sometimes in the morning and be like, oh, last night that was a bad dream. But usually it's not a nightmare. Nightmare you wake up from and your heart is stimulated, your adrenaline is pumping. That's usually a nightmare.
Are there issues that children or folks can have if they have nightmares on a regular or a reoccurrent basis that could be a problem that needs to be addressed?
Sometimes we do see post-traumatic stress in children. It's well publicized or well written in children who were affected from a hurricane in New Orleans.
Katrina, yeah.
Yes, and it's known for that. We also see nightmares in adults after they come back from war, the war veterans, post-traumatic stress disorder. So we usually try to ask a question and say, is there anything behaviorally wrong with children? Sometimes parents are taken aback from it, and it's just to confirm or refute that there is nothing going on otherwise.
Very interesting. Our guest this morning is Dr. John Bishara. He is with the WVU Physicians of Charleston, the Pediatric, Pulmonary, and Sleep Management, located at the CAMC Women's and Children's Office Building, 830 Pennsylvania Avenue, Suite 408 in Charleston. Their phone number is 304-388-1552, 388-1552. We're taking phone calls this morning, and I like to give this disclaimer every time we're doing a medical-related show. If you or someone that you know is suffering from a problem you want to call in, and you're more than welcome to use your middle name or a different name or something like that, because I know sharing personal information on the air sometimes can be a little bit intimidating. So you're welcome to do that. And these issues that we're addressing this morning and that we're educating on, these are important, and they can affect the lives of your loved ones, and especially the great unknown where you don't know what some of these what these symptoms are, what the diagnosis would be or treatment. This kind of will help dispel some of that mystery and make you feel a little bit better. You can give us a call this morning, 304-345-5858, 345-5858. A couple of topics I wanted to touch on before we go to our break. Sleepwalking is something else that's kind of on your list of things that you address. And this is something that I've always been kind of confused about. I don't understand exactly what sleepwalking is and when someone is actually sleepwalking. Commonly, again, we talk about how things are translated in pop culture. You see the person with their hands out to the side just kind of stumbling down the hallway, and then you hear, don't wake him up. You never want to wake up somebody who's sleepwalking. And there's all kinds of urban legends and myths that are surrounding it. So sleepwalking, what is it, and what should you do to address it?
So sleepwalking is similar to night terrors in that it occurs usually during the same night, and the children do not remember it. And sleepwalking occurs in a spectrum. So usually it starts off with a confusion or arousal. A lot of families will come to us and ask, well, sometimes I poke my head in and I see the child waking up from bed, looking around and going back to sleep. That's a confusion or arousal. Sometimes they do moan. Once they get up and out of bed, it starts into transitioning from a confusion arousal into a sleepwalking. They look specifically like zombies. They will just look right through you. They're very clumsy. If they walk, they'll slam into everything that is in their path. They won't even see you. They'll just walk right past you. You'll talk to them, and they'll just be mumbling. They won't even realize you're there. We usually do tell parents or other caregivers, don't wake them up, because they can become agitated and hostile. I do see some children that actually have attacked their siblings because they have become very agitated because they're still in that confusional state. So you just pretty much turn them around and get them back into bed.
Is that right? So you physically steer them so when they're stumbling or moving, they motor to a different location. So you just take them to a different location, back to bed.
Correct. And most of the time, we have to safeguard the environment because the rooms may be upstairs and they may walk down the stairs. And again, they're clumsy, so they'll fall down. I've seen families where children fall down the stairs. I've seen children go to the bathroom, and it's actually realizing that it's not the bathroom, but it's the kitchen.
Oh, yeah.
So that can happen. I've seen some children pick up certain utensils. I'm not saying a spoon or a fork. They'll actually pick up a knife, scissors. So we usually say to families, you have to make sure the environment is safe and lock the doors, put a nice gate up on the top floor because we don't want these children to fall down the stairs. The biggest factor that goes into sleepwalking is we have to make sure they don't have sleep apnea. If they do snore, have pauses, gasps, or they're getting sufficient sleep. And different ages have different requirements for sleep. Adults is easy, 7 to 8 hours. Teenagers or 12 to 18-year-olds will say, all right, we kind of recommend 8 to 10 hours, and as you go down, you need more hours of sleep. So I've had one child when I was in Los Angeles. The parents needed to beat traffic, so they would wake the child up 4 or 5 o'clock in the morning to get them to school. And they would wake them up every day and would say, well, child's only getting 6 hours when they really need 8 to 10 hours of sleep. So we kind of recommend that to parents. And what is surprisingly, when you dive into the family history, a lot of adults, a lot of the parents or grandparents or uncles and aunts may have sleepwalking.
I was going to ask you about that. So there is sometimes some commonality among family members.
So it is genetically inherited. So we asked them, was anyone that had sleepwalking? They're like, oh, yes, his Uncle Bob. Yes.
And with sleepwalking, is that something that you basically are going to have to manage your whole life, and sometimes it might disappear for long amounts of time, or is it something that will eventually go away? How is that usually resolved, if at all?
Most of the time, I usually ask the families, how often does it occur? Sometimes they'll say, oh, once in a while. Then I would say, look, they'll usually grow out of it, usually by adolescent years.
Okay.
Sometimes when it becomes frequent, we do talk to families and say, what time does it usually occur? And we try to break that cycle. Wake them up before, have them reinitiate sleep again, and usually they'll fall back into the sleep cycle, and it's quite appropriate, the treatment. Sometimes when it's very often, we do talk about medication, but it's very rarely we have to go there.
Having a fantastic discussion this morning. Dr. John Bishara is here with us, and we're talking about sleep problems with adolescents as well as with pediatric problems and in pediatric pulmonary as well. If you have any questions this morning, give us a call, 304-345-5858. Wanda from Nitro has done that. We're going to take Wanda's call right now. Wanda, good morning. How you doing this morning? Are you with me, Wanda?
Yes, I'm here.
Okay.
Thank you.
Great. What's your question for Dr. Bishara?
When I was a child, I dreamed over and over that someone was under my bed. And when I would wake up, I would be afraid to move. So I never went to get my parents or anything because I thought if I moved, that whoever was under my bed would get me. Later, I have suffered severe depression all my life. Would those two have anything to do one with the other?
Sometimes what we see as young children, we have nighttime fears. And the nighttime fears may be secondary to bad dreams or nightmares. And it can, when we wake up during a certain time of our sleep stages, usually where the dream state, the body protects itself and make it yourself paralyzed. So if you wake up during this certain stage, the body is naturally paralyzed. So sometimes bad dreams and nighttime fears may carry forth, and young children, as they get older, they may have these mood issues, mood disorders. So it could have been relating, or there could have been something prior to that induced bad dreams or nightmares.
Okay. I had these dreams repeatedly, over and over and over, the very same dream. Also, I have another question, or maybe a comment. When I had a grandchild, she had night terrors, and when I first turned on the radio, you all were talking about that. Her parents did not tell me about this, and I was keeping her one night, and she woke up with the night terrors. And her younger brother said, "Grandmother, don't bother her, just put her back in bed."
Correct. So usually that was not nice. That they should have made you aware of this. You probably did not sleep the rest of the night because of that.
Yeah.
Yes, usually night terrors is like the young man said, don't bother them, just get them back into bed. If you want to hold them to get them a little bit drowsy to induce sleep, that's totally appropriate.
I was trying to shake her and wake her up, and her brother said, "Grandmother, don't do that. Just put her back in bed."
He's absolutely right.
The youngster was used to it in that case.
I was glad he was there. And you were right. I didn't sleep the rest of the night.
I could imagine that that could be quite frightening. Wanda, anything else this morning? We appreciate your phone call.
That's it. Thank you
Thank you very much. Thanks for listening. That leaves a line open for you, 304-345-5858. Just briefly before we go to break, I wanted to touch on what Wanda brings up there is interesting, because I read a book years ago, and I'm sorry for not sourcing it. I used to own a bookstore, and so sometimes books just came in and out, and I would read them and not really remember. But it had to do with how a lot of our superstitions are tied to problems that came with sleep problems. You talk about the night terrors and things like that, commonly associated with like demonic possession and stuff along those lines in different cultures, including Western cultures throughout history. Things like that could happen. I think it's interesting that as we start learning more and more about that, we can see historically how these things have been misinterpreted so much. It's pretty amazing as far as that goes. And in a situation like what Wanda ran into at a different time, years and years ago, hundreds of years ago or something like that, that would have been, you might have called the priest if something like that happened. You wouldn't really know what was going on. Very interesting stuff indeed. You can give us a call this morning. We're having a great discussion. Dr. John Bishara is here from the Pediatric Pulmonology and Sleep Management Center at WVU Physicians of Charleston over at the CMC Women's and Children's Medical Office Building, 830 Pennsylvania Avenue. Their phone number is 304-388-1552. You can call us this morning at 304-345-5858, 345-5858, just like Wanda did. You can also find out more information online at WVUPC.org. We're going to take a break, and we'll be back shortly and finish up the program right after this. You're listening to Ask the Expert on 96.5, 104.5, and 580 WCHS.
Your smile can save someone else's. Garib Dental Group has teamed up with the Give Back a Smile program to provide life-changing smile restorations for domestic and sexual violence survivors. When you have your teeth whitened at a Garib office, 100% of what you pay for your whitening treatment is donated to Give Back a Smile, a simple way to make an incredible gift. Go to GaribDentalGroup.com, choose your office, and get ready to change a life. Give back a smile with Garib Dental Group.
Good morning. No accidents to report. The only problem is for folks in the area of 39 Hillcrest Drive in Charleston, where the entire road is blocked by a mudslide. If you see traffic issues happening, call the traffic hotline at 304-346-9951. Traffic brought to you by City National Bank, where you can purchase or refinance your home with a no down payment mortgage. City National Bank, equal housing lender. For a convenient location close to you, log on to bank@city.com. This is Jeannie Kay on the Voice of Charleston, 96.5 FM and 580 AM, WCHS.
You're listening to Ask the Expert, WCHS, the Voice of Charleston. Thank you so much for tuning in on this Wednesday morning. My guest in studio this morning is Dr. John Bishara. He is from the Pediatric Pulmonary and Sleep Management Center for WVU Physicians of Charleston, located over at 830 Pennsylvania Avenue. More information online, WVUPC.org. That's WVUPC.org. We might have time for one more quick phone call, or two, if they're quick enough, at 304-345-5858. But I wanted to wrap up the conversation this morning with Dr. Bishara, talking about a couple of other things. Just briefly, we wanted to talk a little bit about infant sleep disorders. I didn't want to dominate that conversation too much because it seems self-serving with me having an 8.5-month-old, but there are issues that surround infants from time to time. What are some of the common things that you need to be aware of with infants?
So sometimes parents will report, my baby doesn't fall asleep or my baby wakes up in the middle of the night. How can I help him or her with their nighttime issues or the bedtime problems? Sometimes, and this can happen at any age, it doesn't happen necessarily in only infancy. The biggest recommendation I tell parents is when you're going to place your infant in bed, make sure that the baby is drowsy, not sleeping. And very good studies done after the baby is 3 months old has shown that sleep training can be done in this age group. So we tell families that you have to place your infant back to sleep but drowsy, so the baby is able to fall asleep, him or herself. And that's the most important. As they wake up in the middle of the night, as they get older, they're usually crying and the families run to them because they have trouble falling back asleep. If they're put into bed in their crib drowsy, it usually helps them self-soothe themselves and they can fall asleep. And that's the biggest, most important point a lot of sleep doctors, especially some sleep researchers, see in young infants. They have this sleep association issue. Mm-hmm. Sometimes they need mommy or daddy to be in bed with them. That's the biggest no-no. You know, I tell families, children are very good hostage negotiators. They will get you to do what they want. They'll just have to scream. They just have to cry. You're already sleep deprived, so you just want them to
go to sleep.
So fine. Get Bobby in bed. They're happy, you're happy, but at the end of the day, it's really not conducive to proper sleep. We have to break that cycle and get them sleep. They need to be associating sleep time with, all right, I gotta self-soothe and I gotta fall asleep myself. I don't need mommy, I don't need daddy, I don't need Nana or granddad. I just need myself to fall asleep.
So if the child is fussy a little bit, you can soothe, get them to a certain point. And it's interesting that you bring this up because just through trial and error, I've kind of discovered with my baby, when I hold her until she's asleep and try to put her to bed, it often wakes her up and then she just gets agitated again after I get her down. However, if she's just starting to rub her eyes and doing the obvious things that tells me that she's getting sleepy, oftentimes if I just leave her alone, she's going to fall asleep anyway. And when she starts getting sleep, we're transferring her to her bed. That is the best time. And hear you say that this morning. I literally just stumbled across this within the last few weeks that it seems to work. So I wish I would have known earlier. But that's great advice because it does seem to work. And she sleeps really well normally. But when I get her to bed, that seems to be the easiest way to do it. A quick follow-up to that, when we talked about sleep issues that infants might have, and it's funny because it kind of ties in with the night terrors earlier. It's happened with my baby twice, and I'm sure other parents have ran across this, where she just wakes up instantly in the middle of the night and just lets out a wail that will last for 10 seconds or something, wakes everybody up, and seemingly goes right back to sleep afterwards. And I've not been concerned about it because it seems like just something that probably happens, but is that true? Is that just something that happens with infants from time to time?
So infants, when you compare it to adults, they have different sleep.
Okay.
Infants have more active sleep in the regards that when you compare it to adults, they spend 50% of their time sleeping in dream state. So they're very active. They coo, they wail, they move around, they smile, they make these noises. And a lot of parents are like, why is my baby moving around? Why is my baby active when they should be sleeping?
Mm-hmm.
That's normal.
It's just normal.
It's normal. They'll wake up because they have more arousals compared to us. Fine. They'll wake up and they'll be able to go back to sleep. Sometimes I tell families there is this whole different types of sleep training. There's the Ferber method or the Ferberization, or there's a little bit more gentler approaches. Sometimes parents will say, all right, I'll let them cry themselves out, but I'll give myself 5 minutes. I will go back into the room and help them, soothe them off, and get them back ready to be fall asleep. And that's totally appropriate as well. It all depends on the different personalities of the parents. Some need to rush into the room very quickly. So we usually tell the families, look, give it some time, a minute, 2 minutes, and be able to prolong yourself when the child wakes up crying to soothe them.
It's Dr. John Bishara, and we only have about a minute left in the program, and I didn't mean to do this, but I kind of shorted one topic we wanted to talk about this morning, and that's cystic fibrosis, something else that you address at your location. Just briefly, in about 20 seconds or so, cystic fibrosis, what is that?
So it's a genetic disease. It's usually inherited, one gene from the mom and one from the dad, and it affects both really the lungs and the stomach. Really, when I say the stomach, the nutritional system, and that they're unable to really absorb the proper nutrients. We do have a CF center in Charleston, and along that lines, we also have an asthma center that we take care of patients with.
WVU Physicians of Charleston, WVUPC.org, 388-1552, 304-388-1552. Dr. John Bishara has been my guest this morning. Have a great day, everyone. This has been Ask the Expert on WCHS, the voice of Charleston.
580 WCHS-AM, 96.5 FM Charleston, and 104.5 FM Cross Lanes, a West Virginia Radio Corporation station. It's 9 o'clock.
From ABC News, I'm Sherry Preston. President Trump wrapping up his dinner with North Korean leader Kim Jong-un at their summit as the president's former fixer arrives on Capitol Hill. More on the summit in a moment, but first, Michael Cohen set to launch allegations at his old boss. Here's ABC's Aaron Katursky.
Michael Cohen arrived on Capitol Hill to appear before the second of three committees taking his testimony. He brought with him copies of 2 checks that Cohen says were reimbursement for hush payments to women. Cohen also intends to say President Trump knew as a candidate that WikiLeaks was preparing to release stolen Democratic emails. Cohen is further prepared to suggest his former boss knew about the infamous Trump Tower meeting with a Russian lawyer.
Cohen this morning calls this, quote, the craziest day of his life. Now to Vietnam, where President Trump has been sitting down with North Korea's leader Kim Jong-un. ABC's Karen Travers is traveling with the president in Vietnam.
President Trump has said recently he's in no rush to see a complete denuclearization by North